Okay, recording started.
Right. You can advance the slide here. All right. So today's session, we're talking about asymptomatic bacteria versus UTI infections, as well as just kind of some myths about UTI. So just to get us started, I know a lot of you are familiar with these terms and concepts, but a lot of clinicians are not, because some of this information is newer for those who have trained a number of years ago. So we'll take it to the next slide. And just to get started about what is asymptomatic bacteria, so also known as ASB for short. So that syndrome, or we medical terminology, it basically means bacteria that exists in the urine without causing symptoms of an infection. So, well, when we say UTI symptoms, we're talking about bladder pain, pain with urination, urinary frequency, etc. When we refer to asymptomatic bacteria, it could mean one or more species of bacteria, and it may be at different quantitative amounts. So if you see it on culture, it may grow various amounts, and it can grow greater than 100,000 of a particular colony, like E. coli colonies. But without signs and symptoms of an infection, we call this asymptomatic bacteria. And we do have UTI guideline or ASB UTI guidelines by the Infectious Disease Society of America. We'll refer to a few of those. Those are in revision. They're just undergoing final evaluations, and hopefully we'll have those soon within the year. Next slide. So as you may guess, asymptomatic bacteria is incredibly common. As women age in particular, we see it really post-menopause. We see a lot more bacteria develop, but there are other conditions and patient characteristics that are also prone to developing asymptomatic bacteria. Some of those include diabetes mellitus, older age, especially as those who live in long-term care facilities. Those who have a history of a spinal cord injury, that usually involves neurogenic bladder. That is an incredibly common situation where you develop asymptomatic bacteria. And those who have had some kind of instrumentation or surgery of the urinary tract, in this case, like a kidney transplant, can also develop it. And then, as you may see all the time, those who have catheters or Foley catheters inevitably develop asymptomatic bacteria. And if someone has a Foley catheter long term, it's 100% chance they're going to develop bacteria. Next slide. So we're going to cover Loeb and McGeer criteria next month. We have a whole session dedicated to it. So for these next couple slides, I'm just going to reintroduce them as just concepts, but like I said, we'll cover this much more in depth next time. So Loeb criteria are used for a patient who you are concerned that may have a UTI. So this is a tool that can be used to help a clinician determine if they want to start antibiotics. The Loeb criteria divided based on if a patient or resident has an indwelling catheter or not. And so you can see the criteria listed here. So if someone does not have a catheter, then they can report painful urination. Fever is going to be criteria in both. And then similarly, if you do not have a catheter, you can have urgency, frequency, more commonly may have suprapubic pain. So kind of once in a while, you can see microscopic hematuria. You can also have frank blood in the urine. It's a less common symptom of UTI. In both, you can have costovertebral angle tenderness, which should alert you to concern for a kidney infection. And then urinary incontinence if no catheter. On the catheter side, we have rigors and delirium added as well. So just to also point out that cloudy or malodorous urine, confusion, fatigue, and falls are not on this list and are not considered UTI symptoms. Next slide, please. So when do we use Loeb versus McGeer? So as I mentioned, Loeb criteria is a clinical decision tool that helps you assess the patient whether they meet criteria to work up and treat a UTI. Obviously, yes, this is the time where you're deciding whether to send a urine sample. But in this case here, you don't have that information back yet. So McGeer criteria is a surveillance tool. You're going to use this as a look back. So after a patient or resident was decided to determine to have treatment for UTI, this is going to help you go back, see what the labs were, urine culture were, and decide if the antibiotics were appropriate or not. And this is, in this case, you're going to use diagnostic information to determine. So both of them are used as antimicrobial stewardship tools. And like I said, we will cover this more next month. Next slide, please. So there's so many UTI myths. We don't have time to cover them all, but we're going to start with the first myth is that UTIs cause confusion. So next slide. So it is incredibly common that part of a workup for someone who has an acute change in their mentation should be ruled out for UTI. And that is, as in long-term care facilities, extremely common to have mental status changes. As you saw before, the residents who are most likely to have asymptomatic bacteria are going to be prone to having, and are in a facility, it's going to be common that anytime that there is an acute change in mentation or otherwise, no matter if you check the UTI when they have that mentation change or when they're completely at their baseline, they're often going to still reveal they have bacteria. So that information isn't as informative to help you decide if that acute mental change is due to UTI. So observational data does suggest that patients with delirium are more likely to have bacteria due to advanced age and comorbidities. And the concern, if you attribute a UTI to asymptomatic or to a UTI, delirium to a UTI, if you treat it or not treat it, the concern is you're missing the underlying reason for that change in mentation. So what we, and then we have some data here for a observational data in that delirious patients comparing those who were treated versus not treated for UTI. And results show that there was no difference in their functional recovery, no changes in mortality. Those who were treated actually had poorer functional outcome, and they were more likely to develop C. diff. So again, we don't want to miss the bigger issue of what's causing that mentation when we're correctly attributing it to UTI. Next slide, please. So what are the causes of altered mentation? There are so many, and I just kind of summarize it here. There are many predisposing factors for someone to have confusion, and just a few are listed here. This is a JAMA Network Open study that you can look up if you'd like to know and dive in a bit deeper. But top of the list for predisposing factors is, of course, advanced age and dementia. As someone has poor functional status, then altered mentation is going to be more common. So I know you all see this all the time. So this is probably no surprise. So what is the precipitating factor that tips someone over into having an acute change in mentation? So many things. You can see that this study just had 112. So there's a lot, but some of the top ones here, obviously somebody's undergoing surgery, anesthesia, more likely to have delirium. Any organ dysfunction, kidney failure, liver failure, can be more predisposed. Obviously, pain, urinary retention itself can cause altered mentation. So urinary retention, but not UTI. And then I won't list all of these, but you can see there's so much to consider. So it's really got to be fully investigated before, so we can kind of trigger and treat that patient's mentation. Next slide, please. So this is an IDSA, Infectious Disease Society of America guideline recommendation that in older functionally cognitive impaired patient with non-localizing symptoms to distinguish ASB from UTI, that those who do not have local genitourinary symptoms or other signs of infection, such as fever and hemodynamic instability, that you observe that resident patient carefully without antimicrobial treatment. And this is where we have some language that we can share at the in our interactive portion here at the end that can help with those discussions. Next slide. Okay, so myth number 2 is that treating asymptomatic bacteria will sterilize the urine. So let's say someone's decided, well, I know they're not having symptoms of a UTI, but I don't want that bacteria there, so I'm going to treat it with antibiotics. So next slide, we're going to debunk that myth. In this study, this was a randomized controlled trial of 35 patients with long-term indwelling catheters. So again, this is a population we know is 100% likely to have bacteria in their urine. They underwent weekly urine cultures, and those who were positive for bacteria received 10 days of cephalexin or Keflex. In the graph below, you can see the top line are those who were not treated and those on the bottom that were treated. In the first figure, it's showing that, sure, you treat and the number of bacterial strains may decrease, but when you look to the right, those who are susceptible changes over time. So as you give cephalexin every time you have a positive urine culture, you can see the susceptibility dropping. Versus with the not treated, you see a nice steady maintenance of cephalexin susceptibility. So what are we doing when we treat? We often do not sterilize the urine. We may decrease the bacterial burden to some degree, but it's temporary because those bacteria become resistant, and we will never achieve sterilization of the urine. Next slide. So this study followed a cohort of non-catheterized residents from 5 nursing homes. They started with over 500 participants. Some that 311 were not suspected to have a UTI. Of the 240 that did have a clinically suspected UTI, ultimately 27% were observed, 48% received one antibiotic course, and 25% had greater than 2 antibiotic courses. So in their results, if you click again, what happened with attempted treatment of the asymptomatic bacteria is that, of course, those who were treated, you can see antibiotic utilization was high, so that's expected. But the development of multi-drug resistant gram-negative urinary isolates was increased for those who were treated, which was statistically significant. Those who were treated or not treated, there was no change in mental status or difference in hospitalizations for UTIs. So ultimately, did treating the asymptomatic bacteria do anything in these non-catheterized residents? No, we developed more resistant organisms and used additional antibiotics that were probably unnecessary. Next slide, please. So the 2019 Infectious Disease Society of America's guidelines for asymptomatic bacteria recommend against screening for or treating asymptomatic bacteria in most clinical scenarios. And you can see all of them listed here. So next slide. Myth number 3. So ignoring asymptomatic bacteria will cause sepsis or death. I'm going to go through next slide, thank you, is a study, as a cohort study from 30 years ago that asked if asymptomatic bacteria in older ambulatory women was a marker of increased mortality. So what they did was collect urine samples every 6 months from afebrile and otherwise asymptomatic women. And if they had the same organism and that grew at 100,000 colony forming units or more, they were treated with a number of antibiotics. They were treated either with trimethoprim, sulfamethoxazole, or Bactrim, or cefaclor, or amoxicillin, carbenicillin, or nitrofurantoin. This sample aspect of their table 1 is shown here, and this gives you an idea of the 318 women who had bacteria. So the primary outcome mortality was not different between the two groups. And bacterial cure, control versus treatment group, they actually did end up reducing the bacteria in a bunch of these patients, but there was no difference in mortality. And I think the big reason why we don't see cure nowadays is because of the development of resistance. So next slide. So there has been, again, that was 30 years ago. So now we've seen a lot more information published. So what the best summary I could dig up was this meta-analysis published in 2022 by some Australian investigators. And their aim was to report the effectiveness, harms, and adverse events associated with antibiotic treatment for older adults with asymptomatic bacteria residing in long-term care facilities. This meta-analysis included 9 randomized controlled trials, which encompassed 1,300 participants. And these were all studies that they were treatment versus no treatment of asymptomatic bacteria. Their outcomes that they looked at were mortality and UTI development. And then secondarily, they looked at antibiotic therapy-related adverse events. And what they found was that asymptomatic bacteria treatment was associated with higher bacteriologic cure, but also more adverse events. So their conclusion was that the risks outweigh the benefits of treating asymptomatic bacteria. So with the thought, like the goal was you can cure the culture, but you're not curing the patient or helping the patient long-term. So next slide, please. So let's switch over. Now, what if it is a UTI? Let's say they do meet criteria. Then antibiotics are warranted. So we go through Loeb criteria. Let's say the resident is having localized urinary symptoms, frequency, frequent urination, dysuria, etc. So then what do you choose? So I think it's important here to establish the difference between a complicated versus an uncomplicated UTI. And I'm going to say there is a lot of confusion about complicated and not uncomplicated. I think the simplest way to think through categorization of UTI is to think about upper and lower, meaning is there an infection of the bladder alone, or do we think that the infection has ascended through the ureters and is now infecting the kidneys? And as opposed to using some of these well-established, maybe becoming myths about, a male is a complicated UTI no matter what. That was something that I was taught, and many clinicians are, but we're finding that shorter courses, even for males with UTI, are sufficiently treated with short courses of antibiotics. So for simplicity, I think it's easier to consider, again, bladder, or do we think there's kidney infection? If we are confident or thinking this is a lower urinary tract infection, meaning it's bladder or below, they're not having flank tenderness, for example, then your first line therapies are nitrofurantoin, which can be given for 5 days, versus trimethoprim sulfamethoxazole, which can be given for as short as 3 days. Some of our second line therapies include ciprofloxacin, and as we know, ciprofloxacin and fluoroquinolones, the reason they're on the second line and not first is because they have of their adverse event profile. And the beta-lactams can also be used, and the only reason they're in the second line therapies is because of resistance development. However, it is becoming more in favor, so it's really about your antibiogram. If you have E. coli, Klebsiella pneumoniae rates with high first-generation cephalosporin susceptibilities, then it can be a great choice. With beta-lactams, we just have to treat longer, so from 3 to 7 days. Next slide. All right, this is for our online viewers. If you are attending here in our session today, you do not need to fill this out. Next slide.
All right, just stopping recording now.